I love to start with this slide because it does two things. It shows you my diverse background in healthcare, number one. Number two, it shows you that I can't keep a job for very long in healthcare or anywhere else. So I started my training as a nursing home administrator. And then after a few years in a nursing home, I was asked to come join a hospital to be its CEO. And after being a hospital CEO, found myself as an acute rehab hospital CEO. And it's amazing in our country how few people, even in healthcare, truly understand what acute rehab is. And I recall when I first took that job having to ask that question, and they said, don't worry about it, everybody asks that question, but if anybody could figure out what acute rehab is, it's somebody who's run a hospital and somebody who's run a nursing home, because we're right in between. So I thought that was really cool, and then I ended up being the vice president over post-acute services for a health system. Really before it was cool for health systems to have post-acute folks, because it was right after the Affordable Care Act was passed, so it was a neat time to do that. Most of you have heard this story before, but I started in sports marketing, and after a few years in sports marketing, was having a great time, was able to work with some professional athletes like Mark McGwire, the year he broke the home run record, and do some fun things. I got to fly on a private jet twice, once there to New York and once back, and I've never been on a private jet again since then. But it was on that private jet on the way back that I looked at my wife of 3 or 4 days and said, hey, this is amazing, this is awesome, I'm living my dream, but it's not fulfilling, and I want to look for some other career that I can do that will be fulfilling. And that's about the same time that my grandmother was going through what I call the fee-for-service merry-go-round. She was going from the hospital to the nursing home, home. 3 weeks later, she falls again, and there's just a collective cheer from all the providers in the community because we get to bill again for Josh's grandma. Let's send her to the hospital, and let's send her to a long-term acute care hospital for 25 days. And then after that, why not? Let's send her to a nursing home for 3 more weeks. And as you can see in the letter that she wrote me, even before I was in the healthcare sector, it says, hey, I've been institutionalized for 4 months. And I remember reading that, and it just broke my heart. And that's the time that I made the change to train as a nursing home administrator, and a few years later was fortunate enough to become a hospital CEO. But as you can see on the slide here, one of the reasons I like to share this slide is because during the fee-for-service era, doctors and hospitals got paid for providing a service to a patient without any accountability, without any checks and balances. And the Affordable Care Act at its heart was to put criteria in place and to put checks and balances in place for us as providers. And it wasn't a great time for providers because we had no accountability, quite frankly, leading up to the Affordable Care Act. If a doctor said this patient needs care, the patient needed care. Again, it was called the fee-for-service era. I like to call it the fee-for-service free-for-all, and what I just described to you was my grandmother in the summer of 2002 riding the fee-for-service merry-go-round because there were no checks and balances, and if a doctor said she needed the care, nobody questioned it. Did anyone ever tell my grandmother that she had a right to go home? No, nor did they tell her significant others or caretakers in the family. And that's what we're looking to change as we move towards value-based care. And one thing I will share with you, this is such a time of change in healthcare in America. When we look back at the Obamacare era, and did you guys see that study that said 60% of people thought that Obamacare was something different than the Affordable Care Act? You know, everything's a little bit confusing in this day and age, but if we can all agree that the Affordable Care Act and Obamacare were the same thing, the legacy of Obamacare is really undebatable. It expanded access to health care. No one will debate that, but in this contentious time in our country, there's plenty else to debate about how we got there, but that's not why we're here today. Its legacy will be very simple. Undebatably, it expanded access to health care benefits. That will be its long-term legacy. So, this is my brother. I mentioned to you in 1998 he played for the Dodgers. Same year that I worked with Mark McGwire, and everything was going great until my grandmother wrote me that letter and a student approached me and said, hey, I think you'd be a great addition to our nursing home company as a leader. And so I went and made a career change. So, a few years later, the Affordable Care Act passes. We go from this time of no accountability to a time of everything requires criteria, the federal government refusing to pay you or penalizing you if you admit a patient to any level of care that didn't need to be there. And I remember when I first made this slide, I had it in my slide deck in 2011, 2012, and a good friend of mine who's now running Culver City Hospital, at the time was running Marina Del Rey, he called me one day and said, hey, this is the slide that really spoke to me, Josh, because we were both young CEOs who ran independent hospitals, and it was really important for me to hear from you that I can't think like an independent hospital anymore. I have to think like a bigger health system, and health systems have to think like managed care organizations. And the Obama administration had a goal called Better, Smarter, Healthier that required every health system, not required, but encouraged every health system to get 30% of their Medicare patients in to an alternative payment model by last year and 50% by next year. The Trump administration has not addressed that goal. It was not a rule. It did not have a penalty. But do you remember, a year before January of 2016, the feds released a press release patting themselves on the back saying we're a year ahead of schedule. And that was encouraging because that meant health systems were actually transforming to value-based care for the first time, because we saw very little movement from 2011 until 2015. So this slide simply says hospitals need to act like insurers whether they're part of a health system or not. The other thing that this slide is here to convey is that hospitals, and you heard this earlier from Rod from USC, you're going to hear it later from Dr. Feinberg and others, the health system must take ownership of the patient outside of the hospital. And I call that ball control. Do you know why I call it ball control? Because several people said to me years ago, Josh, I don't like you referring to patients as balls when you say ball control. Well, you remembered it, so here we go. Ball control, really simply, means this: if the health system doesn't control the patient during the SNF stay and during the home health stay, SNF being skilled nursing, they're spending your money. And remember this, I was trained to do it, and so were several people in this room. We're trained to work in complete contrast to your objectives of value-based care. We're trained to extend length of stay, keep people there as long as we can, give as much therapy as we can, whether they need it or not. When we're in the meeting with you telling you what a great partner we're going to be, we're not going to share those things. We're going to tell you all the things you want to hear. But if you don't control the ball and leave that length of stay determination to us, let our doctors and therapists determine what the patient needs, we haven't changed a thing from the fee-for-service era, and we're spending your money. Thanks. Thanks for the open checkbook. These are 7, I think it's 7 on this slide because I keep adding them as we go, 7 programs that the federal government has given hospitals to incentivize them to transform from fee-for-service to value-based care. The last one, guys, is actually for skilled nursing. It's no longer proposed, it's now official, and you're on the clock if you're a SNF. You're being measured by how much money the federal government spends on your SNF plus the 90 days after. And several of you have heard me speak or write and say, Josh, why do you say that SNFs are going to stop referring to home health and start referring to non-medical home care? Well, this is why. Because the SNF's going to get penalized for every dollar spent by Medicare after the patient leaves their SNF. And if you and I own that SNF and we get a penalty for money somebody else made, we're not going to refer people to that company much longer, are we? It's capitalism, and it always comes back to that. Better, Smarter, Healthier, starting at the bottom here, I mentioned that was an Obama administration goal that hasn't been addressed yet by the Trump administration. But when you look at the rest of these, the readmission penalty program, accountable care organization, bundled payments, they all get back to the same thing. If you admit a patient to your hospital that didn't need to be there, we're not going to pay you. In fact, we're going to penalize you. And really the only one of these objectives that hospitals paid attention to for the first 4 years after the Affordable Care Act was passed was the RAC audits, which wasn't even part of the Affordable Care Act. It was the only penalty program that got the attention of most hospitals for the first 4 years. It was the accumulation of these things that started to get the attention of the hospitals and started that journey towards value-based care. And guys, there's exceptions to every rule, and I will tell you, most of the people on this stage today represent the exceptions. They come from organizations who started this process when they were supposed to in 2011 when the Affordable Care Act passed. I want to make one point about Obamacare, Trump care, whatever you guys want to call it. Okay? It doesn't matter if it's Obamacare or Trump care, value-based care is going nowhere. And there is not one person on either side of the aisle that has said since election night that we're going back to fee-for-service. Not one person has said that's possible. And here's the simple reason why. You remember being in college or being that age, your checking account was empty? The federal checking account remains empty, and it continues to be drained at an alarming rate. No one is saying we're going back to fee-for-service. Well, except for a few SNF and home health owners who think it was a great time. No one making decisions is making that suggestion. So what we learned on election night, although Obamacare introduced value-based care en masse, election night was probably the first time most of us said, hey, What's going to happen to value-based care if the Republican majority is in charge? And the answer is it's going to be tweaked, but it's not going anywhere because there is no alternative other than to put a system in place with checks and balances. So what does this mean, guys? It's an insurance model. Hospitals are being forced to be insurers. They're being forced to manage the entire patient episode. Remember, in the future model, 80% of the time a patient presents to the hospital in the emergency department, it was a failure of the system being population health, focusing on keeping you well at home by eating well, staying in shape, encouraging self-management, and making sure your caretakers have the tools they need. So hospitals are no longer a profit center in value-based care. And I know this isn't a popular statement in this room, but it's a fact. Hospitals are the largest expense in the new model. And if you need further explanation, have somebody explain to you the structure of Kaiser Permanente. That's largely how value-based care was modeled. And I've never worked for Kaiser, but I would venture to guess at their monthly operating meeting, they don't sit down and say, did the hospital make money this month? They sit down and say, did the business make money this month? Because the business is the business. The hospital is the largest expense. There's a big difference, and that's a huge transformation for us in our head, because like many of you in this room, I spent 10 years as a hospital CEO, and that's a far cry from how I felt and the emotions I felt when I was sitting behind a desk making decisions for a large organization that provided care. The hospital's no longer in charge. It's a bigger business model. The model that you're hearing from today from others on this stage is the model of the future. And I'm appreciative that they're all here to discuss that. We talked about ball control, and this message on the bottom, guys, is mostly for post-acute providers. The federal government does not care if you go out of business. I'm sorry to be the one that breaks the news. You see a hospital across this country going out of business or filing for BK every day. I see home health providers closing their doors, and with all due respect to the home health providers in the room, that's long overdue. Because my hospital and every hospital in this room is required to add all of you to our list. And we have more than 100, and that's irresponsible and it's impractical. And I've shared that message with CMS and with the folks from MedPAC, and they don't necessarily disagree. They're just looking for a better answer as to how we can narrow our network and work with one provider or 3 providers that provide great care. Now, we've talked about this at length before too. There is a difference between patient choice and patient steering. There is a fine line. And as Harry mentioned earlier today, in the old days, the hospitals paid our attorneys to tell us to take the high road, which means they confused the issues and said choice and steering are the same thing. They're absolutely not. I'm going to make it really simple for you. This is America. You can go wherever you want, whenever you want, and that will never change. That is patient choice. Even if you have an HMO, you can go to whatever hospital you want. You might have to pay more, but you can go wherever you want. Patient steering is when a hospital says, hey, we went and toured all 18 of our skilled nursing facilities. We're narrowing our network to these 8, which, by the way, we are allowed to do. We're not restricting patients from going anywhere, but we're going to share resources with these 8. That's called our narrow network. We're going to soft steer them there. If the patient says, I prefer to go elsewhere, then we'll say, that's great. We have a great relationship with that SNF. We will facilitate that transfer immediately. There is a fine line. There's no longer time or reason to debate it. Choice is different than steering, and steering is alive and well. It's encouraged in value-based care, and it is mandated by the federal government in several alternative payment programs. You must send patients to a 3- or 4-star SNF in several alternative payment programs. That, by definition, my friends, is steering by the same people that many people say prohibit it. This is the hospital of the future, and that's the emergency department. What are the alternatives when a patient goes into the ED other than admitting them to the hospital? This next slide I call my purple slide. And if you're a post-acute provider, this should be your #1 marketing tool. Go to the website, print it out, take it to the emergency department, 10 copies every time you go, and help train the emergency physicians who don't know about post-acute care, don't care about post-acute care, and have never had any incentive to care or learn about it. You take it upon yourself to say, here are all the other dispositions that patient in your bed can be covered by under the Medicare benefit. Other than admitting them to the hospital unnecessarily, you can send them to the observation floor. You can send them to the physician's office or urgent care, which is now 24/7. You can send them to an LTAC. By the way, you could always send them to an LTAC. This is not new. It's called site neutral. They don't make much money off of it, so they're not going to tell you that until you call and ask. even though LTACs are closing all across the country, because we perceive them to be post-acute care, even though they're not, they're acute care. When we as managed care organizations look and say, oh, post-acute care, I can spend $1,500 a day at this LTAC, $1,200 in acute rehab, or $400 at the skilled nursing facility, I'm going to challenge you again. If you and I own that company, my question is, why did you call to ask? We know where we're sending them for $400 a day. But the LTACs can take those patients right from your emergency department. Just call and ask. Acute rehab, you can admit a patient from a street corner. I know. I was trained to do it when I worked for the acute rehab. All I need is a physician order and an assessment on site. And it is not hard in the fee-for-service, free-for-all era to get a physician to come to my building and do an assessment. Somebody took offense to that once when I said that you could admit somebody to a street corner. The fact is, you can. I was trained to do it, and I have. All you need is a physician assessment on site. In SNF, if by definition you understand the readmission penalty, somebody who discharged from an acute hospital in the last 30 days, that patient can go to a SNF without going back to the hospital anytime. And that SNF will be happy to take it. Because as you know, if they have Medicare, the SNF asks very few questions and says, yes, we'll take that patient. I want to cover, before I close up, a few best practices that I've seen as I've traveled the country. The spring and fall, I find myself traveling the country 3 or 4 days a week presenting. And as I meet folks, and even this morning I've met a few that I'm going to follow up with because they appear to be best practices. You're going to learn a little bit later today about AMADA. You heard from Chad. They have a discharge avoidance program called DART. It's a readmission prevention program that I learned about when I was traveling the country in San Antonio, in Austin, and a few other cities. And it's a great program for a non-medical home care company that traditionally wasn't thought of as health care. If you're a health system and you're participating in bundles, you need to understand what the LUPA is. A low utilization payment adjustment. And I'm going to give you the 10-second version. You can ask me later to give you the 2-minute version. The first 4 visits of home health, the federal government pays $125 a visit. If a 5th visit is needed and taken, the federal government rolls that to a $3,500 payment. The federal government is spending your money because it's a bundle now. So I've had several people in this room that are on panels today saying, hey, so guess what? We're in bundles. We don't do a 5th visit anymore. And I want to thank those of you who taught me that, because it's not very often that I get to learn those things from you anymore. And it was awesome to learn those things. Thank you. Hospitals are buying home care franchises. In Orange County, St. Joseph's bought franchises of non-medical home care. The debate as to whether or not non-medical home care is part of the healthcare solution is over. It's no longer a debate, it's a fact. And also, guys, when we talk about scripting from a nursing home to non-medical home care, or from a hospital to non-medical home care, you guys all know this. Several don't want to acknowledge it, but let's just put it on the table. When your physician says we get our best results by doing X, the answer for most patients is, I'll do X. And if that means non-medical home care is our preference, remember earlier today when I asked for a show of hands, which one of you can't wait to be admitted to a convalescent home? Not one person raised their hand. This is where this scripting comes in. We know that every American would prefer to go home. We want you to know you have a right to go home. We want you to know we think you will need these resources if you go home, but we also want you to know there's a few risks involved. And that leads me, guys, to, you're going to hear later from Stryker, who's got a whole services management division to help with bundles. And I actually called them after seeing them at a post-acute network meeting and said, hey, I saw your video. I heard about the data you're aggregating for bundles. I would love for you guys to come share with the audiences at our events what you're doing, because hospitals need to hear from you. And you're going to hear a little later from Leslie on that. You're going to hear also from Patient Ping, and what I love about Patient Ping is Jay Desai, their founder, used to run the Medicare Innovation Center. He saw an opportunity to connect hospitals to post-acute, left and started it, and it's taken over the country so quickly it's exciting to watch. You also heard from Abbott today. I also call this my free to hospitals slide, because a lot of these solutions are free to hospitals. And what I love about Abbott and the Advocate case study that you heard a little bit about today is it's simply self-management of nutrition being encouraged and scripted by the hospital. Scripting on discharge is so critical. And then also you're going to hear about our 2016 National Readmission Prevention Collaborative Innovation Contest winner. It's a sternal vest with an infection control coated material that just blew the judges away and was an unanimous winner for unanimous winner for our 2016 innovation contest, and you're going to briefly hear about that from Sandy after lunch. So with that, guys, this is the Discharge with Dignity model that several of you have asked me about today. I designed this several years ago and started introducing it en masse in the last couple of years. This is a tool designed for hospital case managers, and actually you can use it in the skilled nursing facility as well. The goal is, as a case manager, to start at the left. And remember, not one person in the room raised their hand when you asked who wanted to go to a nursing home. So that's one of the reasons I designed this. The other reason was to remind your case managers and your hospital staff that the more you institutionalize folks, the redder this gets, meaning it's costing your hospital and health system more money. So we're going to start at the left. We're going to try to send everybody home, which is green, the color of money. If home is not safe and they have the resources for assisted living is green as well. And then you move to the olive green, which is the two transitional care management codes and the chronic care management codes that Medicare now reimburses for, that in my estimation, guys, needs no justification for an assessment for any patient hospitalized over the age of 65. You need no justification beyond those 2 or 3 stats to say, let's see if they could benefit from a visit in the home within 72 hours, or if they could visit from monthly chronic care management. On a side note, chronic care management is very difficult. I've only seen it being pulled off one place in the entire country. It's an organization out of the Midwest that does it all for the doctor, and the doctor collects the reimbursement. I have their contact information if you're interested. So this was designed for 2 reasons, guys. Because Americans want to age and heal at home, number 1. And number 2, your hospital discharge planning staff needs to know that they're spending your money every time they send a patient to a SNF, which is orange, okay, and acute rehab or LTAC, which is red. I had a panelist a few months ago who's somebody I really admire from Kindred Healthcare, one of their leadership, and as you all know, Kindred's core business for many years was long-term acute care. And she came up to me and said, this guide is so good, I just don't like it because I'm an LTAC. And I appreciated her honesty. Because this guide is what every health system should be using for discharge planning, not because I'm a CEO who knows how to manage the money, because my mom is the patient and so is yours. And we all want to go home. And we see it every day that we're not told it's an option, we're not offered it as an option. And I'll close by saying this about this guide. This is about communicating with patients. Skilled nursing facilities, when I ran them, had 2 college degrees on my staff of 300, mine and 1 others. So when hospitals say, I don't have time to talk to the family, I'll just let the SNF talk to them when they get there, yeah, that's going to happen. Here's what I need for my mom, and I would imagine you need for your mom. Mr. Luke, your mom has 7 needs on discharge. 4 of them are covered by her benefit. But like every benefit, that Medicare benefit is capped. You are allowed to say that, even though early in my career, several seasoned executives told me, you can't talk about things that aren't covered by the benefit. Oh, that's wrong and inane, quite frankly. And they also said you can't talk about things that are covered beyond the benefit. That's incorrect as well. What I need from you folks is to tell me the 7 things my mom needs, and then tell me the resources I might need to accomplish them, whether she has a benefit or not. And then we can decide, when you let us know, we think your mom would benefit from post-acute institutionalization, but she can go home, and here are the risks. That's the conversation that needs to take place. That's Discharge with Dignity, guys. I'm going to wrap up by just sharing with you again that what's motivated the National Readmission Prevention Collaborative to become a not-for-profit and to donate proceeds from every event we do to Alzheimer's support and research is my mom being diagnosed in 2010. So I want to thank each of you for being here and for your support of that cause. And I am very excited to be here today and to learn from each of you. So thank you very much for being here.